Okay. So to anybody that just jumped on, so my name is Katrina Sanchez, and this is Miki Fukusumi. We are both speech language pathologists at the NAPA Center. So Miki will explain a little bit more about who we are, what NAPA Center is, and where we're located and everything like that. But today, our main topic, we wanted to, just sit down and talk with all of you, have an open conversation. We also mentioned to some of the families earlier that feel free to write in the chat and the comments and ask any questions you have, and we'll try to mention and think about and go over some of that information throughout our presentation. And so for now, we're going to give a pretty general discussion about different areas of feeding, what we look for as therapists and things like that. So let's talk about feeding.
Okay, so we work for NAPA Center. It stands for the Neurological and Physical Abilitation Center. We are a multidisciplinary clinic, and so we have PTs, OTs, speech and language pathologists, and feeding therapists. And so we specialize in an intensive model of therapy, and we have a focus on children who have complex neuromotor disorders. So things like disorders like cerebral palsy, traumatic brain injury, hypoxic ischemic encephalopathy, and other genetic or chromosomal metabolic conditions that affect neuromotor involvement. We have intensive programs that consist of all disciplines for 2 to 5 hours daily, 5 days a week for a 3-week program. So we do have families that fly in from out of state. So our main clinic is in Los Angeles, or our home clinic, but we do have some other clinics in Boston, Sydney. We are opening one in Austin, Texas in September. So that's definitely maybe a more doable option for those of you or I guess all of you are in Texas. But our intensive program allows each child to have a more individualized and tailored program. So our rehab director will go through kind of like the intake paperwork and talk with the parents and give the recommendation of, how many hours to do, what kinds of therapy that the director thinks would be beneficial for that specific child. Last year, we launched our intensive feeding program, so that incorporates 2 to 3 hours of feeding therapy. It may include an hour or two of like PT or OT if we feel like the child's physical abilities, like their trunk control, their head neck control, if those things are going to be facilitative for helping them with their feeding, then that also might be in part of your intensive feeding program. And yeah, we're opening Austin in September, so we will hopefully see some of you there. So Katrina is going to talk about what we're going to go over today. Oh, you're muted.
Okay, thank you. Okay, so Miki and I have worked with many, many families where parents have shown, common concerns or a lack of information. They want more questions answered about their child, their whole family's journey with feeding and swallowing. And most families have just needed to have a casual conversation from start to end of, how does feeding and swallowing work? What is it about? What are therapists looking for and deciding how they're going to treat their child? And from there, helping to provide resources and guidance to practice at home so that families could continue doing therapy at home or just, exercise at home in a practical and timely manner. So that's our main goal. So we're going to be looking at what areas affect your child's feeding and swallowing, basic stages of swallowing, just to get a better idea and understanding of swallowing, what therapists look for, common goals in feeding therapy. So it might not show all the goals that we would use, but these are some areas that we would think about or goals that we would think to target for certain areas depending on what your child is working on. What you can do at home. some extra resources that you can, of websites and things that you could go into to help continue learning. And again, like at the end, let's chat. We wanted to make sure to incorporate your comments, concerns, opinions, experiences, and make sure you leave with something and this is helpful and meet new people perhaps. So yep, like I said, it's a discussion. Okay, so sensation versus motor. So we're going to start just talking a little bit about what does this mean. So your therapist might mention areas of like, oh, this is a motor issue, or oh, it's a sensory issue, things like that. And so the difference between the two is that the sensory system sends our brain information about the world around us, right? So we talk about, is our food too hot? Is something sweet or salty? Is a bite too big or too small? And what you feel in your mouth. You know, is there a seed stuck in your tooth? Do you need to swallow again in order to clear something? All of those are feelings, even like coughing and phlegm being in there. Those are sensations and feelings. So that is something we think about with sensory system. Then there's the motor system, where our brain tells our muscles what to do to achieve a goal. So closing your lips around a spoon, that's a motor act, something that you have to physically do with your muscles. Using our tongue to stop water from flowing back too quickly to the back of our throat. Compressing your cheeks to suck. Using jaw muscles to drive your chewing. Propelling your tongue back to initiate a swallow. And squeezing your throat muscles during your swallow. So again, those are all motor things. Those are our muscles having to be used to facilitate what we're trying to do with food and drinking.
Wow.
Okay.
Okay, so sensation, our sensory system directly affects our motor system, and sensation is what helps us drive motor movement. So often we will find that someone who has impaired sensation will then demonstrate oral motor difficulties. So some examples of this are, you know, if your hand touches a hot stove, you sense that heat and then you immediately retract your hand. If you don't really feel like heat, hot or cold temperatures, and your hand is on that stove for a while, you're not going to move your hand because you're not feeling it. So another example might be, you know, when you go to the dentist and you get numbed, and while you're eating dinner, you have food, little crumbs of food on your lips, and you don't realize it. You don't move your lips, or you don't use your tongue in order to swipe, like clear your lip off, the food off your lip, because you are not feeling that sensation. So when we're thinking about our kids, especially some of our kids who are not yet swallowing, there's often that impaired sensation where if they're sounding congested, if they're sounding like there's a lot of phlegm in their throat, and you're just wondering, oh, why don't they cough it out? Oftentimes it's because they have impaired sensation, and so they are not sensing what is sitting in their throat, and so they are having a hard time. They are not realizing it, and so they're not coughing it up. But there's also the aspect of the strength to be able to productively cough something out, or the strength to be able to completely or effectively swallow that phlegm or that liquid completely down into their stomach. So it's an important, though both of those factors are important to and are kind of intermingled. So we'll talk about this a little bit later, but we really need to and want to work on improving the sensation that our children have in our throat, in our mouth, with our lips, all of the muscles that we need for swallowing. We need to increase that sensation so that it drives that motor movement and it makes them use those muscles more consistently. Maybe they're able to bring their tongue back to swallow, but it's not very strong. We want to work on increasing that sensation so that we can, so that they are continuously working on moving that muscle, their tongue muscles, to strengthen it. and we'll touch on that a little bit more, but the other aspect of sensation is we do see some children who have oral sensory defensiveness. And we often see oral sensory defensiveness when we see children who have maybe gone through a lack of oral eating. So I know that a lot of our families, or our families here, their children have experienced a traumatic brain injury. So, and it depends on the age oftentimes. So if your child experienced a traumatic brain injury early in life, like at birth or at a young age, and they weren't able to progress through eating milestones of bringing, tasting different flavors, trying different textures, bringing food to their mouth and eating by mouth, then they're missing these milestones that are important for us enjoying food, understanding textures and flavors, things like that. And also we might have children who have oral sensory defensiveness, children or adults who have oral sensory defensiveness because they've had a traumatic medical history. So things like intubation and surgeries, and just having kind of a fear of things coming at them and in their mouth because they've been in and out of the hospital and they've experienced a lot of that, those things. And these two things we can see these both in a child. We can see impaired sensation, but we can also see oral sensory defensiveness. As a personal story, so my mother had 3 brain tumors, and so she was in a medically induced coma for a few months, and she's doing well now, but being able to hear from her, and so she also had a G tube and was also trached, and she would tell me that just like flavors didn't taste the same way that they used to, even as she was recovering. Things that were supposed to be sweet tasted sour. Things that were supposed to be, a normal flavor tasted too salty. So oftentimes when there's brain damage, sensation is just altered, and that affects definitely like what goes in our child's mouth and how they respond to those feelings. So I just wanted to talk about the basic stages of swallowing, just so that we have an idea of what's going on. There's so many little things that are happening that we don't even think about. But for a child who's maybe never eaten or has very limited experience eating, they have to do so many things with their muscles that we don't realize. So if we're talking about food, once there's food in the mouth, and I'm thinking about things that we need to chew. So once we have food in our mouth, if you have any food with you or close by, I would try this as we're talking about it, just so that you kind of get the idea and you're really thinking about it. But you put some food in your mouth. Your tongue then has to move the food over to your molars in order to chew. Once the food is over onto the molars, your tongue has to hold the food in place, but your cheek is also compressing the food on that molar so that you can continue to chew it. A lot of times what we'll see is children who are at the stage of being able to chew and eat, or maybe are close to it, that tongue strength is not there. So they are able to get the food over to the molar potentially, but they can't keep it there. And so if they can't keep the food on the molar, then they are going to have a hard time breaking down the food enough to be able to safely swallow it. So if they try chewing a couple of times, but the food is still not broken down enough and they try to swallow it, that becomes a choking hazard. So that's step 2. Once we've chewed the food down enough and it's ready to swallow, our tongue is going to swipe it out of the molar and put it on the back of our tongue, or we call it the base of our tongue. And then our tongue is going to move backwards to send that food back into our throat. And through all this, think about too, we have to have appropriate sensation in order to realize when our food is ready to swallow. We can tell just by feeling it in our mouth that the food is broken down enough to swallow it. If we have impaired sensation, we might not realize that we need to chew the food a little bit more in order to swallow it. Okay, so when as we start to swallow, we're going to keep our lips closed and we're going to compress our cheeks so that we can send the food effectively and efficiently back into our throat to swallow. As we're swallowing, our vocal folds have to close shut, and we do that so that we prevent any food from going into the airway, and that that can lead to pneumonia or choking. And then we also have our throat muscles that constrict as we're swallowing to squeeze the food down our esophagus into our stomach. So that's a lot. That's a lot that's happening, all within within a couple of seconds. So it's a lot of coordination that is required. And even if there's no food involved, I'm going to skip to the next. Oh, and let me show you. I'm just going to talk about. So we have our tongue. Can you see my mouse? Okay, so we have our tongue here. And then so once the food hits kind of this back area of the throat, that's when everything is that's when our swallow is supposed to be triggered. So even if it's not food, if it's saliva that's accumulating in our mouth, once it hits this back area, it's supposed to trigger a swallow. So our vocal folds are going to close. This is going to seal off, and then that phlegm is going to travel down into the esophagus here. It's really thin, but it's going to open up to let the food in. So if we have impaired sensation in the tongue area, in the throat area, anywhere along this line, there can be saliva that's trickling back without the child realizing it. And so that's what's causing a lot of congestion and phlegm in the throat area, because they're not sensing all of that saliva trickling back. And so it's accumulating there before they realize. And for some of our kids, once there's a lot of it, they realize they need to swallow or cough. But some of our kids who are not yet swallowing, they are not sensing that in there, and they're not able to then have their sensory system tell their muscles, hey, you need to cough, or hey, you need to swallow. And please feel free, I know this is kind of science-y, so please feel free to interrupt me and ask questions if something doesn't make sense to you. So I won't go into detail because the liquids are pretty much the same process of swallowing. The thing that's different is, so liquids can be very tricky because it's fast. It's so viscous that you really have to have that fine muscle ability to keep the liquid in your mouth until you're ready to swallow it. So there's different levels of thickness. Something like honey or pudding or puree is going to be easier to maintain in your mouth than water. So when the liquid is in our mouth, before we're able to coordinate the swallow, the back of our tongue is going to raise up to make sure that the liquid stays kind of in the front of our mouth. So if you have a drink with you, try this. You're going to hold the liquid in your mouth, and you'll notice that your tongue is raised, and then once you're ready to swallow, the base of the tongue is going to drop down to let the liquid flow back. So you see that in this B picture, the tongue has dropped down. But the same processes apply besides that when we're talking about what our swallow is doing. And so when we're thinking about saliva secretions and mucus, it's kind of like a liquid. It's a little bit, and because it's a little bit thicker is not the right word, but a little bit like stretchy, or that's a very scientific word, sticky. That can be, if you've ever been sick and you try swallowing when you're congested and mucusy, it can be really difficult when it's that thick. I have a question. Sorry. So it says, so kiddos, I'm going to read the question out loud, if that's okay. It says, kiddos with brain injury could not possibly even have the neurological ability to know they need to swallow. This is correct. So kids who have a brain injury, the brain injury can cause damage depending on where it is. The damage can be in a place that affects the nerves. So all of our muscles are connected to nerves, and nerves are like the chain of command from our brain sending information down to our muscles and telling them what to do. If that area of the brain is damaged, then those connections may be weaker, or some of those connections might not be there. And so that's why they're not realizing that they need to swallow, because that chain of command is broken or is weaker. Does that make sense? But with kids who are with young kids, there is something called neuroplasticity. I'm sure some of you have heard about it. But even with adults, some of us, we all have the ability to have parts of our brain that are undamaged take on the control or the functions that other parts of the brain were supposed to do or were doing before the damage. So that's why therapy is so important at a young age and so early on, is because we can really capitalize on that neuroplasticity and make them grow and help them grow new connections with the other parts of the brain that are functioning more appropriately. And Jenna, my daughter is also drooling and sometimes does not realize it. We have also noticed that she does not feel when food is sitting on her lip, mainly her left side. Is this part of left side neglect and weakness? I would say yes. That is generally the case. So because she has the weakness there, her weakness is also stemming from impaired sensation. She's not feeling the drool kind of slip from her lip. So she's not going to move her muscles to stop it from happening because she's not feeling it. So Jenna, for you, I would say it's a lot of increasing the stimulation inside her mouth. We'll talk about this a little bit more. So dysarthria, the dysarthria treatment manual can help. It depends on what areas are being affected, because sometimes dysarthria, you're talking about the voice and the throat muscles. And so if you're focusing on the voice or throat muscles, that doesn't work on the lip and tongue muscles. So we'll talk about some of those. We can talk about some of those exercises in a little bit too, that you can do at home to increase sensation. Okay, Katrina, go ahead. You're muted also.
Okay, perfect. Thank you, Miki. Okay, so now we're going to go into a little bit of once we see a child, we sit them down and we start to look at your child. This is some of the areas that we're looking for. So we're trying to figure out, where is the feeding problem coming from? So based off of all of those things Miki was just describing, now we hone in to figure out where it's coming from. So we'll look at, are they having dysphagia or dysphagia, which is difficulty swallowing? Is there oral motor dysfunction? So are they having difficulty using the muscles of the mouth to speak or chew or drink? So again, those are the lips, tongue, teeth, cheeks, or palate. Or are they having any sensory difficulties? So that they may stem from, like Miki said, from hypersensitivity, which hyper means extra or up more. So more sensitivity, and oral sensory defensiveness. Which is how she was mentioning some of the kiddos that have had, a little bit of trauma or something from, being in the hospital or things being poked and prodded or being intubated. They might have more defensiveness. So those are some sensory areas. So the questions we would ask are, or ask ourselves, first of all, something we always look at is, how is their GI system or their gastric system? There's always potential medical issues that affect that. And so, like, I believe one of the moms was saying that, her daughter keeps on throwing up and they're trying to figure out what is happening and having so much reflux. That's something it's not so much in our realm. It's more so the GI that would work through that. However, there are things that we can work on that help. In terms of children that might swallow and are not swallowing solids, if we could increase the amount of solids, sometimes that also can decrease the amount of reflux. There's a variety of areas that we can help work in, and we talk with your GI as well with that. So first, we would also talk about, does your child safely swallow food and liquids? We would also then go into our oral motor difficulties or impaired sensation, the primary cause of the feeding problem. And we would ask, is the oral sensory defensiveness maybe that they might be showing the primary obstacle to eating and drinking? So there might be different areas that that we would look at before we go into any treatment.
And maybe, sorry, Katrina, maybe here we can kind of talk about because we weren't sure what our audience wanted to talk about, but it does sound like a lot of we have some families here that are talking about spitting up and some GI issues. So some of the things that we always try to kind of ask parents about that don't necessarily involve us, but we work in tandem with their GI and making sure that some of these things are taken care of is a lot of times anything that might be causing inflammation in not only the stomach or the gut, but also our esophagus can cause difficulties with eating. So we know reflux is a huge one, and it sounds like quite a few of our kiddos have that. Oftentimes when they're on formulas, that causes a lot of reflux. So we do try to push or encourage a blended diet, and it sounds like some of you guys are on blended diets, which is great. Blended diets, it's just real food. It's what our stomachs are meant for or made for. It fits in our gut better, and so there's less of the refluxing oftentimes when they have real food blends. Another thing could be allergies. So if you've never gotten any allergy tests, or maybe you can also develop an allergy, I would look into trying to see if there's any allergies that might be there. And an allergy doesn't always mean they're breaking out in hives, or they have or it's something more severe. Yeah, but it can definitely cause ulcers in the stomach. It can cause inflammation in the esophagus or in the gut. So and then oftentimes if you have a formula that has a lot of different ingredients in it, they could potentially be allergic to something in the formula. So I would definitely look at changing or seeing if you can rule out any allergies. Things like thrush in the throat, you might not see it in the stomach or in the tongue, on the tongue or in the mouth, but you might have thrush in the throat, the esophagus, and that when you swallow that down, that goes into the stomach. And thrush is a infection, like a bacterial infection. This is often related to allergies, but esophagitis or eosinophilic esophagitis, it's like a type of allergy too that causes inflammation in the esophagus. Some other things that we ask when we were just thinking about gut health is how often are they having bowel movements? If they're constipated often, or if they're not having regular bowel movements, then that can definitely, that backs us up. And with children, children often they listen to their bodies better than we do. We have so many years of us, knowing it's lunchtime, it's time for us to eat. Even if we are full, even if we're constipated, we still end up eating because we know it's lunchtime, it's 12 o'clock, it's time to eat. Children are not that way. And that's why oftentimes, for those of you that have toddlers, it can be so finicky also because they really listen to their bodies. Whereas we don't often follow that same thing. Regina, Nourish and Real Food Blends, those are considered blended diets. So those are not formula foods. Some formulas that are kind of in between, like the real food blends and the Nourish, are things like I think Complete Pediatric, Kate Farms. Those are still considered. Those are considered closer to like real food blends, but they are still considered formula. And you can see that when you're talking about, or when you look at like Kate Farms and Complete Pediatric, they their flavors are still just like vanilla or chocolate or like a normal flavor. We also, sorry, I'm switching gears a little bit, but when that formula is in your stomach and you're refluxing it, you're getting a really sweet taste. Yes. And it doesn't taste like, you know, when we burp and we had, you know, a hamburger, you taste kind of like the remnants of your meal. But when you have formula in your stomach and you're burping up like the vanilla flavor, it's not. And if you've ever tasted that formula, it's not that tasty. So consider that that's also what they're tasting when they're burping that food up, or the formula up. Yeah. So I was talking about, sorry, I lost my train of thought. We were talking about allergies. We were talking about real food blends. And then bowel movements and constipation, we need to make sure that our children are regular, and try to get them as regular as they can. If they don't have regular bowel movements, then that's also an area like you can try to take care of with Miralax, or, you know, talking to your doctor and having them prescribe something to try to make their bowel movements more regular. Especially that can be something that's causing them to spit up too, is their stomach is still full from their first meal, and we're trying to give them another feeding, and they're still full. They're not passing that. So that can be a cause of spitting up as well. The other thing is, I lost my train of thought again. Bowel movements.
Inflammation in the stomach.
Inflammation. I'm missing something.
Delayed gastric.
Yes. Go ahead.
So that there's often also something called delayed gastric emptying, where the stomach, so the food goes into the stomach, but it's not necessarily passing through into the intestines. And correct me if I'm wrong with any of this, Miki. But so you'll find that there's kids that will eat their food or they'll eat through their G-tube or whatever it may be, and then 2 or 3 hours later is when they're throwing up. And so that's not necessarily just reflux, that's something else. And so that's a common symptom that you'll notice in children with delayed gastric emptying, where the food is just not being processed through past the stomach. And so that's another area that can be checked. And there's, I believe, pH probe. There's some tests that can be done in order to figure out where it's coming from and are they having delayed gastric emptying. So that's something you can talk to your doctor or your GI about. I believe some of those are inpatient, like hospital stay type of tests, but it is something I definitely recommend. We've had, I mean, Miki and I think both have had patients that have had delayed gastric emptying. And it's really hard to move forward or get anywhere when you're trying to work on things with the mouth and their stomach is still full because they're delayed and they're emptying. And you can see where the GI issues can affect what we're trying to do with the mouth, where if the stomach is not being, is working the way it's supposed to, and they're constipated or they're having other issues that are causing also more reflux, then on top of that, sometimes the reflux could create more of like an aversion, I guess, or a defensiveness with the mouth, because they know now whatever goes next to my mouth or whatever goes next to my G-tube is going to hurt or is going to bother me. So making sure that gets taken care of, or at least you start that conversation with your doctor, is really important. And another thing I was going to mention, Miki, that kind of goes along with the gastric is looking at medications. Mm-hmm. So there's medications that can affect, even from up here all the way down through the stomach, can affect a child's, their appetite. It can affect how much saliva they have in their mouth or a lack of saliva in their mouth to be able to swallow. And so there's medications that also impair their sensory system, that decrease the ability to feel a swallow. So those are some areas that I suggest you also talk not even as much to your doctor about, but to the pharmacist. So many families try to talk to their doctor about these things. And while doctors do know obviously about medications and things like that, pharmacists have a wealth of knowledge of medications and can look at all the symptoms right there on their computer. And so trying to keep all the medications your child might be on with one pharmacist rather than multiple is actually another thing that would be better. That way your pharmacist can compare the different medications they're on. You won't lose track. They won't lose track of any other medications. And they can compare and see if any of these medications are affecting your child's ability to sense a swallow, to produce saliva or not produce enough, or too much, I mean, and a variety of other things. So that's something I really do suggest that you bring up and look at your medication list. And on top of that, sorry to add one more thing, is that just keep in mind there are medications that if your child has cardiac issues or respiratory issues, some of the medications kind of what's the word? They go against, they interact. So there might be more of a limited amount of medications that you can switch to not have certain symptoms that you're trying to avoid. So just keep that in mind. If there's a medication that is causing a certain symptom, see if they can change it to something that's better. Otherwise, we can always try to work with that medication, but just keep that in mind.
Yeah, I know this is a lot of these are literally all of the questions that we are trying to think about when we are seeing a patient for the first time, and we're trying to ask ourselves all of these things and kind of nitpick through all of these. So the gastric delay. So Regina asked, the gastric delay can be due to neurological issues too. So it's not quite that's not quite our realm. I can't speak to that. There may be multiple causes from that. It can be an allergy. It can be, if it's the actual motility of it, that can potentially be neurological if it's the muscles that aren't able to accept the food. But I do think that it's something about the absorption of the nutrients and things like that. But that would be a question for your GI doctor that could better answer that. The one other thing, so kind of on Katrina's point, when we're seeing so many different providers, a lot of times they are giving the medications from their aspect or their realm, so they are not realizing all of the different medications that the child is interacting with. So that's definitely something that is a great point that Katrina made. The one other thing that I wanted to talk about in terms of GI issues is also thinking about their feeding schedule, or what their meal times look like. So Katrina and I most often recommend being on a pump versus a gravity bolus, or using a syringe to push the food in. And the reason that we recommend this is because you are able to keep your hands free and interact and have a meal with your child, versus your meal times looking like you are, or just being you pushing the syringe, pushing the food in through the syringe. Even if our child is not eating much by mouth, this is an opportunity to be stimulating their mouth and giving them an oral experience while they're eating. We want, especially for those of us, and this might be, something that you're thinking about down the line, but if we are hoping to get our child back to being off a G-tube and eating by mouth, they need to have an experience that's very similar to if they were already eating by mouth. So that means that we are giving them that oral experience connected to their meal times, their G-tube feedings, so that they have the idea that when my mouth is stimulated this way, I'm also starting to feel full. We want them to make the connection between taking something by their mouth, even if it's just a little taste. You take a little cut of strawberry and you're just rubbing it on their tongue. So it's not anything volume. It's not a big volume, but it's just the flavor. They're getting the flavor of something, and they're connecting that with their stomach getting fuller. So we also then want to think about how long are their meal times. If you are pushing, if you're pushing 8 ounces through a syringe in 5 to 10 minutes, we don't eat that way. We don't consume that much in such a short period of time. And so often, and our stomachs would feel so full if we did that. If we took our entire meal in within 5 to 10 minutes. So oftentimes when we're seeing retching and vomiting during meals, it can be because their stomach is stretching to a point where they don't have that space, and we're giving them too much in a short period of time. So with a pump, you're able to feed them, their bolus at a continuous rate over a period of 30 minutes, for example. We like to keep our meal times around 30 minutes if possible. But that way they're not getting so much at once. They're kind of slowly getting full. You have your hands free to work on some oral motor or oral therapy type of things. So that's also kind of an area that we look at.
We look at a ton of areas. Trying to give you, I guess, a bit of more and more information, but
I think those are the main things. Okay.
Yeah.
We'll keep
going. And
going.
it actually perfectly flows into your next slide, Miki.
Oh, yeah. So is this right? Oh, yeah. Okay. So some common goals in feeding therapy. So first we want to ask ourselves, is our child orally defensive? If our child is orally defensive and they're not very tolerant of you touching their face, their lips, they don't like when things are in their mouth, they gag when they like taste the flavor or when you put something in their mouth, these are signs that they're orally defensive. And so for an orally defensive child, we need to build their tolerance and their acceptance of stimulation to their mouth. And so we want to provide these more enjoyable experiences with food and flavor. Any sort of stimulation, so stimulation can be increasing, or stimulation can be through touch. So you're rubbing their cheeks. Maybe you have a towel, a wet towel, and you're touching their face. You're giving them pressure in their mouth or on their tongue. So not too hard, but especially if we have that impaired sensation. So like Jenna, this might be, like Jenna, this might be something that you could do with them. I know that she's not orally defensive, but just like you're increasing the sensation in her mouth. Something like a toothbrush, or like a child toothbrush that's the silicone head, or a Z-Vibe. If you guys, we can talk about Z-Vibes, but anything like any kind of oral motor tool, you want to give them stimulation inside their mouth. You can dip that in, a little bit of puree. You can dip or rub that on a little bit of a fruit or a soup and put that in their mouth. So that's kind of going into flavors. You can change the temperature. So you can put a spoon in the fridge and make it cold, or a spoon in the freezer to make it cold. And then using different textures. So something like a teether that might be bumpy, or a hard carrot. We know that they're not going to bite down on it or break it off, but it's just something that you can put in their mouth that has a little bit of different texture. So for a child who's orally defensive, we really want to make sure that we're just increasing their tolerance and their acceptance of stimulation in their mouth. That is going to be the number one priority. If they don't enjoy things in their mouth, or if they are fearful and won't accept things in their mouth, then we can't move past that, because they are not going to be comfortable, putting anything in their mouth. Sorry, I kind of skipped ahead when I was talking about the sensation, but for a child who's not yet swallowing, but doesn't necessarily show any oral defensiveness, that's where we really want to get into their mouth and try to increase this sensation in their mouth, because remember we talked about sensation drives motor movement. So maybe we can go through, Katrina, you and I, or later we can go through like more of the specific exercises and things that we can do with tools to increase sensation in their mouth. Do you want to do that? Maybe with the tools that we have that we show later on. Good question. So what are you looking for? What kind of reaction are you looking for when you do stimulation, like a cold spoon? If it's a cold spoon that's empty, like it can be an empty spoon, I would put it in their mouth and give them a little bit of pressure on their tongue and swipe it forward. And what I'm looking for is I'm just really looking for any reaction, any movement of their oral structure. So maybe their tongue moves back and forth a little bit. Maybe their cheeks move. Maybe they bring their tongue to the top of their mouth. I'm looking for, and so it depends on every kid. It depends on where the kid is on their, in their swallowing journey. But for a child who's like not really doing much of anything with their mouth, I'm just looking for changes in reaction. And maybe it's not even maybe it starts off with just, eyes kind of widening, but you see that they're responding in real light and kind of reacting to the stimulation. But you keep on doing that, and over time, then you'll start to see a little bit more movement. Maybe, after doing that for a few months, you see that they move their tongue a little bit, or you see that their cheek moves in response to that reaction. So we're just wanting to wake up their mouth and increase that sensation so that we can see more motor movement.
Right. I was going to mention that we've had children that we work with that are not moving their, barely maybe even moving their tongue, and just providing input like from the back of the tongue, let's say, or on the sides of the tongue and pulling forward. You start to notice with, different temperatures on different spoons or different little like probes and stimulating tools, you'll notice that you'll start to see the tongue pull back or move sideways following the tool, ever so slightly, even to start. And then from there, that's where you build the momentum, and you can get that tongue moving more, you can get them feeling more, and moving forward from there. So it might even start as such a small movement, and that's what you still have to pay attention to.
Mm-hmm. And also just remember, it's like going to the gym. Like, you do it once a week, you might not see changes or gains or very many gains that for a while, but if you do it a bit more consistently, and it takes quite a few, it might take some time until you start to see changes. So the tongue is a muscle, our lips are muscles, our cheeks and our throat, those are all muscles, so we have to be working them out regularly to be able to facilitate that change. Does anyone have any more specific questions about this? We can kind of talk about maybe the specific exercises in a little bit. Okay. So for a child, is this you, Katrina? Me. This is me. You. Oh, sorry. Okay. So for a child who has oral motor difficulties, we have, I think Jenna is eating food by mouth. We want to increase their oral motor coordination and then build their endurance with these exercises. So an example is if they are not chewing their food, if they're not able to break down their food very well. So it sounds like, I think when we were talking, Julie, you had mentioned that you have to chop up the meat really, really finely or small. So we want to work on her building that endurance and the strength in her jaw to be able to chew a bit more. So what you can do is you can take something that she doesn't have, that we know that she's not going to choke on. So for example, maybe you were talking about steak earlier. You take a big strip of steak. It's not something that she's going to put all in her mouth at once, but you're taking that strip of steak, you're putting it on the side on her molar, and you're having her do 10 hard chews of that steak to work on that muscle. And then you do it on the other side, 10 consecutive chews of the steak, and just working on building the strength of that muscle. There's also oral motor tools that you can use, but since she is eating food, I think you could just use food that's harder, more firm, something maybe like beef jerky, licorice, thinking of other things that are, meat generally is a bit harder to break down. So steak is a great option. Anything that, requires a bit more effort in order to break down. I wouldn't do something like a carrot. If she can break off a carrot, then that poses a choking risk, because if she breaks off a piece that is too big for her, then that can be a choking risk. But something that maybe doesn't break off, that she can continue to work on that chewing skill.
Some families will even do like frozen bagel strips or frozen French toast strips, and like frozen things as well. That also gives you the temperature stimulation.
And then we like to put food on the sides on our molars, because that's where our chewing, most of our chewing happens. You can work on that tongue muscle too by putting, for her, maybe you're putting strips, like a little bit of bigger strips, putting it on the tip of her tongue and trying to have her move it back to the molar. So you're lateralizing your tongue from side to side. So you're working on that movement, and then just making sure that she's chewing it. Is she, Julie, will she spit out food or not swallow it if it's too big? Okay, so she'll try to swallow it. Okay, so then I would probably be a bit more careful about that. I wouldn't have her work on that quite yet. I would just work on those bigger strips and putting it on the side, and just having her work on chewing, but not swallowing it yet. So this wouldn't be something you would do at a mealtime necessarily. This would be something maybe you do as like an exercise during a snack time, maybe, because it would be frustrating to have to like practice strengthening your muscles when you're hungry and you just want to eat your food. So this would be something that you would work on outside of a mealtime, I would say, just for like 5 to 10 minutes working on strengthening. For anyone who has maybe a weak swallow, and you might see a weak swallow because maybe you give them, some oatmeal. They swallow the oatmeal, but you see a lot of stuff still hanging out in their mouth. We call it residuals. Or like soup, they swallow the soup, but you still see bits and pieces left over. Oftentimes we see that that's maybe a weakness with the tongue, they're not getting all of the food back, or a weakness in the cheeks. They're not sucking all the food down efficiently. So we can work on those, or that oral motor ability, by giving pressure or stimulation to the base of the tongue, to the side of the tongue, on the inner cheeks. You're rubbing the inner cheeks with a toothbrush, an oral motor tool, a clean finger. You can get your hand in there and just kind of rub the inside of the finger, of the cheeks. And remember, we always say sensory drives motor movement. So you're stimulating those areas in order to increase the muscle movement.
Oftentimes you can even just give another spoon bite, but without anything on it. So we'll call it give them a clean spoon. And the child will kind of get stimulated as if they're about to take a bite again. But really, you just want a clean spoon so that they're swallowing again anything that's still left in their mouth. And oftentimes that'll help clear it up. So that's a nice little trick that I often do.
Yeah. So with sipping, I don't think do we have any families right now that are kind of at this stage of sipping from a cup or a straw? If I have no response, then I'll say no, because then I'll just skip over that. Okay. What is she drinking from now? is she, I know that she's having, okay, and she's having, she's just feeling uncomfortable swallowing the liquid, correct? Okay, we have another family.
Mm-hmm.
Can you guys maybe, if you guys don't mind, sharing a little bit of like where your concerns are, just so that we're tailoring our information to you.
If people want to speak out loud, that's totally fine. That might help a little bit.
Yeah, that would be great.
Yeah.
You can unmute yourself if you want to share. The Hiranis.
Yes.
Hi, can you hear me?
Hi.
Hi. Yes,
we can hear you.
Hi. Our concern, so basically we've been practicing for a while with my daughter to chew on the sides of her mouth. And so she's gotten a hang of that, but then the idea of taking food, and I know you touched on it a bit, but like to take food to the sides, when we do present it in the middle, like she immediately still wants to suck on it.
Mm-hmm. Okay.
Then, or sometimes she just spits it out because it's too big of a bite.
Okay. So, so you're kind of in between, you're putting food on the sides, but not quite able to get her to move things over. Yeah. When she, okay. Does the food fall off of her molar? Like sometimes if she's trying to chew it, will it fall back onto the tongue and then she coughs or spits it out?
Sometimes, yeah, it does.
What I typically do when kids are doing that is and sorry, one more question. Is she emerging, or is she able to like move the food over at all when it's on her tongue tip?
She can, but she seems to immediately, like, she goes to that preference of just sucking the food and then taking it back.
Mm-hmm.
Instead of taking it to the sides of her mouth. So she'll do it occasionally, but then it's almost like I'm having to remind her to take it to the sides, and then it seems uncomfortable for her, or foreign for her to go bring it to the sides and then bring it to her mouth or to her throat.
I'll give you my, and then Katrina, if you want to share too. So one thing I would think about is if the food is soft or like able to be sucked down, then sometimes that, because it's so much easier to just suck it if it's like meltable, or if it's something that's not super, that she needs to actually really chew, sometimes that can be a reason that she's sucking it instead of moving it over to the side, because it's just so easily like able to be broken down. If it's not that texture, do you have any like toothbrush, Z-Vibe, any kind of like oral motor probe or something, or even kind of like just a smaller spoon, or like a silicone spoon? If you put something there on the tip of her tongue, you can, once it's there, you can take your probe. So say it's like it looks kind of like a pen. You would swipe it over onto her molar, and her tongue should follow it. So you're showing her what her tongue needs to do, and you're making her tongue follow that pattern when you're using the probe.
Okay.
So that's something that we kind of do more repetitively in therapy when we're kind of at that phase of trying to bridge the gap between the food just being on the side and using the tongue to get the food over on the side. The other thing that we will do is, instead of putting it so far back onto the molar, we're slowly inching our way more forward into the middle, but still kind of following along the lines of the teeth. Does that make sense?
Yeah.
Okay. Katrina, do you have anything to add for that?
No, I was going to agree the same thing of just placing on lateral sides. I think that's the number one way of increasing lateralizing, or moving the tongue to the sides of the teeth to help hold the foods in. I'm trying to think. There's also, like holding, you can always do like the chewy tubes where you put food inside the little tube and hold it there on the sides to help just maintain on the side, the food on the side. So as it comes out, you can also just get the child used to chewing on the side. As the food comes out, they're feeling it on their side, and the tongue just naturally starts to follow it more and more and maintain it. But that's the most I would say besides what you were saying.
Mm-hmm.
Mm-hmm. If the child is able to copy you, then I know there's families that also have, you can do like Fruit Loops or Cheerios or things like that to try to have the child move that object to the sides as an actual drill exercise, but that is a little bit more advanced.
Carrie, I just saw, thank you. I just saw your question. Is it easier or better to work on the swallowing with a G tube versus sorry, it's escaping me, an ND. Oh, an NG tube.
I think that's what she meant.
Do you mean an NG tube?
The nasogastric?
ND.
ND.
Is it, oh, nasal, sorry. Okay. Yeah, Katrina, do you want to?
I've worked with a child who had, it was an NG tube, so it's still a nasal gastric tube, but so this from their doctors and in the hospital, typically they don't let them leave with the NG tube. This family that I personally worked with left with an NG tube because the family didn't want the G tube and they just continued. So we were able to personally work on oral feeding with this child, and they were able to remove it once he was orally eating, and he was with the NG tube for a few months. Typically, we recommend that we not to continue feeding with the NG tube or an ND tube because there is that, based off of research, there is research that shows that it can create more of an opening. And I think the idea comes from more that if you have a tube there and you're squeezing the food down, it's kind of like when you wear a ring for a really long time, that once you move that ring, there's kind of that indentation. And so if you have a little bit of that extra space, once the tube is removed, when you're trying to swallow, you have a pocket there that decreases the ability to push down the food quickly and efficiently. So it's one of those things that I've seen kids go for a while with one, and luckily they were able to get off, and they're still having, you know, some difficulty, but they can't pinpoint it if it was because of that or not. But then there's research that goes to show that it can create permanent issues. So that's maybe something. Yeah, go ahead, Miki.
And the discomfort too that, you know, that can come with it, just having something there in your throat when you're swallowing. It can affect. Yeah. It can affect the swallow, you know, your ability to swallow and be kind of uncomfortable. So so it's a factor. How long has your son had it? Okay. Yeah. Our recommendation typically is to move to a G tube, just so that it's not causing like any long-term effects. Because that can also cause like some inflammation or some scarring or like hardening around that area. Does he have any reflux issues?
So it probably comes up often too.
Yeah, and so then that's also a consideration, is if the ND is taken out and it's causing kind of like that space in there, then the constriction that you're able to have when you swallow something, that sphincter is not always going to be as strong. So then that what before wasn't as much compared to now. So that can potentially be playing a role, because it's kind of cutting into that sphincter. Your sphincter is maybe weak. The sphincter can potentially weaken over time because there's something constantly there when he's trying to swallow. So, and because that weakens, then the reflex is able to kind of get through that opening a bit easier. So that can be playing a role potentially.
Yeah.
Does that make sense? Thank you. Okay, and then Kelsey. Okay.
Yeah, go ahead.
So it says my daughter, if daughter needs help swallowing, she's at the point where she is just now starting to cough up her secretions. Her secretions pool at the back of her throat, and she will cough or gag them up, and often triggering vomiting her food. Does she swallow at all currently?
She does. She swallows some, and like we can even hear it and see her swallow some. But I feel like a lot of the time it just kind of pulls in the back.
Mm-hmm. Are her secretions pretty thick and mucousy? Or would you say they're more just kind of normal or like typical saliva?
It depends. I feel like lately they've been, she's been having more like allergy issues, and she started teething. She's cutting like 5 teeth.
Ouch.
And so it's been more than usual.
Okay. Yeah.
And it's like foamy white.
Yeah. So with that's typically something that we say we just want to keep on working on her, increasing her sensation, the sensation in her mouth. It's great that she's starting to like feel the secretions and cough it up, but we see that it's still a bit impaired because she's letting it continue to pool. And then once it gets, so for us right now, our threshold, as soon as we feel some sort of saliva sitting on our vocal cords, we know immediately that we need to cough. That's because our sensation is, it's more typical. For her sensation threshold is much higher because a lot more has to accumulate before she realizes she needs to cough.
That makes sense.
So we want to increase her sensation to keep on working on that sensation so that we lower her threshold so that she realizes when she has to cough and that she has to cough sooner than letting it all build up. So that would be, and you can do like what Katrina had mentioned, like using an empty spoon or using some sort of tool, getting in her mouth. Does that stimulate her to swallow? Do you know?
Putting anything in her mouth, she's actually pretty orally defensive. We've been working on that a lot.
Got it.
She was intubated for quite some time.
Okay. So yeah, I think keep on. Go ahead, Katrina. You have something.
I was gonna say, I would try to help her, especially if she's teething. I would give her like maybe some chewies or something, like literally just like toys that she can chew on, that, and you can even stick them in the freezer. There's some that you can put that will freeze, that have liquid inside, and let her, or start to slowly, you don't even have to start straight at the mouth, but if she will take it to the mouth and just chew on it with her gums, don't put any food or liquid or anything else on it. Just let her start to be, does she enjoy stimulation like that, or will she not even accept any toys or anything in her mouth?
She said she was defensive.
Yeah.
She's kind of at the point, like, if you stick something in her mouth, she's stopped gagging in response to it, but she just like chews really, really, really quickly. Like she kind of panics or something.
Yeah.
Okay.
So what you can also do is start outside of the mouth. So don't even really go in the mouth yet. And you can start with some exercises that we'll talk about. Did we mention them already, Miki, yet, the exercises?
No.
Not yet. Okay, there's some exercises that we can always start with. So kids that have more defensiveness within the mouth, you don't have to necessarily go straight in the mouth right away and, freak them out. You can start with the outside and get them more comfortable and then slowly work in.
Okay.
Yeah. So we'll get there in a moment.
Sounds good. Thank you.
All right. Okay. Go to the next slide. Okay. So I think this is me. Okay. Okay. So common feeding therapy tools. So these are a lot of tools that we use on a regular basis. So the nosy cup is the cups on the top left. So those guys, Yes, there. Those guys, they're great for practicing initial cup drinking, where that cutout portion of the cup allows you to hold the cup from the opposite end. So the side that's still long and looks normal, you would hold the cup there. And then you would tilt the cup so that the nose of the child doesn't hit the edge when you're tilting the cup. So the cutout portion would be up by their nose, and you can see and look in at what they're drinking and where the liquid is at. Way easier. They're pretty soft plastic, so you can even squeeze the cup a little bit to create a faster flow, or just leave it normal to keep it going slow. And with these guys, I'll often start with maybe yogurt, or you can do a little bit of applesauce or smoothie, or a little bit of their blended food, something like that. If it depends, I guess, if they're drinking by mouth yet at all, and help them slowly start to put their lips and take on some of that smoothie or thicker consistency. If you start with water, oftentimes it just splashes out and might startle the child. So starting with something slow, and then you can slowly dilute it and get to a water or milk or whatever thin consistency the child might be at. So that's if they're drinking from a cup, or if you're wanting to start introducing cup drinking. That would be a great start. So next would be, where are you at, Miki? It's okay. Then the bear cup. So it looks exactly like a honey bear, and that is what it is. So the point of the honey bear is to start straw drinking. So if your child is able to start taking in liquids and you want to use a straw, you can I would first push down the straw, so there's only about half an inch of it showing up at the top. And then what's great about the honey bear is you can squeeze it to help the child drink, or help the child get some liquid into their mouth, so that they start sucking or start swallowing, and it just takes out some of that extra effort to suck the liquid out initially. And then next would be the chewy tubes. So if your child, let's say like Naz's daughter, how they're working on, trying to get the lateralizing of the tongue, or getting that tongue to go to the side, that's something you can do that helps a child move their tongue to the sides, because your natural instinct is, there's something in my mouth, where is it? So your tongue starts to learn to follow what's in the mouth. So putting that on the sides by the teeth to chew on is great for that. It's also great to teach just chewing in general. Sometimes I'll tell the child, okay, we're going to do 2 big bites. Okay, and then you can even put something in it that's a little bit crunchy. There's a little tube, so you can always stuff it with a little bit of puree or something if you wanted to, or just dip it in water if your child can't have any food by mouth yet. And you can press it down on their teeth if they're not initiating that bite. So by pressing it down, the child will want to push against it and start to try to bite on it. So that's another idea. They come in different thicknesses, so that there's easier ones and there's more difficult ones, also others with different texture on them. Anything else to add, Miki?
No, I was gonna say, yeah, they're different strengths. So like the green and the blue one are a bit firmer, so it's harder to chew them. So you can kind of graduate through the levels of chewing to work on that strengthening.
Mm-hmm. Then on the bottom right corner, there's a probe. It's Miki, it's the arc therapy probe.
Mm-hmm. Yeah, this is kind of like a Z-Vibe. If you guys are familiar, Arc Therapeutic is the company that
name.
This one's called, I think, the mini Prefer probe. But this is kind of like the oral motor tool that we were talking about. There's this one's a bit smaller, which is what I like for some of our smaller kiddos. It doesn't vibrate. There's also a Z-Vibe that vibrates to give like that added vibration.
Mm-hmm. And it's good. This one, it's like Miki's saying, it's much smaller. So a lot of our smaller kiddos with a smaller mouth, we're able to put that in, and it's not taking up their whole mouth. So that is a really good one. And it has like a rubber, like circular type or cylindrical type of tip on it, so you can turn it and twist it and roll it in their mouth without any edges bugging them. So that's a really good one to help work on some of the exercises with the tongue. Sometimes I will dip it in a little bit of juice. I'll dip it in a little bit of ice cream. I'll dip it in some pickle juice, something with a really strong flavor. I even know families that have done, they'll dip it in a little bit of like bacon fat, things with a lot of big flavor that you don't need to put so much on it for the child to feel it is what we're aiming for, especially for kids that are not swallowing yet, because we don't want to risk really having too much go down the wrong way. So doing something like that, and you can even put this on their teeth and push down throughout their teeth on the bottom and the top, again, to try to get that movement in the jaw, to try to create a little bit of a bite and get some movement and sensation going in their mouth. That's our main goal there. Mm-hmm. And then on the top right corner, those are bite blocks. And so you can find bite blocks also on Amazon. These are the purple ones are different than the red ones. The purple ones are just a little bit softer. I personally like them better. And so what these guys do is they help create, it's called jaw grading, where you want your child to figure out where their jaw is in place, how to bite and hold in that place and create strength in their jaw. So if there's a lot of weakness in the muscles of the jaw, in closing and holding things, that's a good tool to use, where you can start from, I personally start from the bigger one and work small. You can work from the small to the big, and it comes with a little manual and everything to explain how to do it. And you would put it between their molars and have them bite and hold it, and you tug on the stick, kind of like almost like a dog bone. You would pull, and the child will hold it with their jaw, and you count up to a certain, amount of numbers until the child can hold it and work through each different stick. Do you use it for anything else, Miki?
No, it's the same.
Okay. And so I believe that's it for those. If anybody has any questions about that.
Before we keep, I know that we've come up to our hour.
Yeah,
mm-hmm. So we can maybe just open it up to any questions, or we can give you more specific, if anyone wants to stay, we can give you more specific like exercises that you can work on. How are you guys feeling? Or Rhonda, what do you think?
Yeah.
I mean, it is up to them if they want to stay on and continue asking questions. I think maybe if everyone just wants to start talking out loud, it might, be helpful. That way you don't have to spend time reading the questions.
Yeah. I'm stop.
Okay.
Or Katrina, we can send the resources and like the information that we have here in an email, so that we don't have to go over, unless there's something that you want to go over here, or we can just send this in.
Do you want to maybe,
is there enough to schedule another support group just to speak on these things, or you can just send me the resources, whatever?
Yeah, I think they're just mostly resources and tips.
Yes, I was going to say the next few are actually pretty self-explanatory. What you can do at home might be a little bit good to explain some of that area, but the rest are very self-explanatory.
The alternative is we can schedule a second meeting and do more specific like exercises and stimulation and tips and tricks like that. That way we don't have to kind of rush through it.
Yeah, if you feel like, there's enough, and if anyone wants to speak up that's still on the call and let us know if you'd be willing to come back for that, let us know.
I think we would be happy to.
Okay.
I'm just going to answer Rachel's question, or Katrina, if you want to answer Rachel's question really quick. It says my son has
okay.
Tongue movements. We have seen side to side, out and in movements. What tools would you recommend, and what steps would you do? What is his feeding? What is he eating? What is he eating? Is he eating anything by mouth, or is he not swallowing yet? And you can speak if you want to unmute yourself. You're welcome to do that.
He isn't eating anything by mouth. He's taking Nourish IG tube, but we have interacted by touching the cheek and the lips, and we see an increase actually in the last 48 hours of lip and tongue motions, and we've even heard him gag a couple times on his saliva.
Great.
But I don't know for sure about his cheek muscles moving quite yet. But we've just seen, even when we're talking to him, we see him almost, it seems like he's trying to mimic us, and he's moving his lips a little bit and his tongue, and it's like he's trying to mimic us or speak, or we really don't know, but there's movement, lots of movement going on, and we're just trying to push towards the whole right now we're just trying to get him off that trach, so and the only way we can do it is if we can get him to clear the airway and swallow, and I feel like we're on the right path. We just want to push it a little bit more.
Is he coughing yet?
He is coughing. He's coughing the secretions through the trach, and like I said before, he would suck it back in because it's a flex tube, and it would just sit right at the end in the HME or whatever, and then he'd suck it right back in when he takes that breath back in.
Okay.
Rachel, does he have a passenger valve?
He does not. He's only had the trach for 8 months. And we'll see his pulmonologist in October, and in August we're going to see his ENT doctor.
Okay. They might bring it up to you, I'm assuming, but I would ask them about that.
From my research, I was wanting to ask and kind of push towards that direction.
Yeah,
that would be one of the first steps.
We can work on, and as you're reaching that, working on increasing or him clearing those secretions, because it does become a bit it can be difficult with the secretions hanging out there. I would recommend, do you guys have any oral motor tools yet?
We do not. I mean, I've had some family members who are nurses say try a pacifier. He doesn't really close his mouth yet.
Yeah.
So how to increase
how old
that.
is he?
He is 2.5.
Okay. So that probe, if you go on ARC Therapeutic, maybe I can pull it up, and
if you go to, you can pull it up. I was going to say on the last page with the.
Do you have it there?
Where to find how? Oh no, I have the Instagram account on there.
So ARC Therapeutic, we can send this in an email, but the probe that we have pictured here, I think that would be something good for him. Either that, or also the Z Vibe, which vibrates. We just want to increase his sensation and kind of try to get him to stimulate coughing, stimulate trying to swallow something down. So any tool like this, when it has a round tip, you are able to kind of roll it onto his tongue, and give him pressure on his tongue. Usually when we stimulate the tongue base, if we keep on pushing on the tongue and kind of stimulating that tongue base, that helps to stimulate kind of getting him prepared to swallow. When something hits the base of our tongue, we naturally want to kind of swallow it back.
Right, the back of the tongue.
So we want to use tools to kind of give him pressure and stimulate that tongue to get that movement, or sometimes that stimulates the cough. So any way that he can clear his secretion, whether it's coughing it up or trying to swallow it down, will be good practice.
Thank you so much.
And then the 90-90-90 rule. So that would probably be, Katrina, if you want to.
So the 90-90-90 rule, it's number 4 on our 10 tips. It has to do with, which is actually a really big area that we could do a whole other talk on, is on the alignment of your child when you're sitting them down to work on feeding or work on any therapy techniques. 90-90 is 90 degrees at the hips, 90 degrees at the knees, 90 degrees at the ankles. So meaning when your child's sitting in a seat, that is the degree at which their hips, their knees, and their ankles should be. So if you're sitting them down and they're sitting up straight with their feet sitting on like a little ledge or something, that they should be able to have those appropriate degrees in those areas. And if their legs are straight or there isn't anything holding up their feet when they're sitting down to do feeding, that it just leaves a lot of insecurity and no area to feel support and secure when your child is trying to support their body to think about their mouth to eat, if that makes sense.
Yeah, it makes a lot of sense. And so, well, Legend, she currently, she sits in her beanbag chair too, and she's on continuous feed for the most part. Yeah. My other question was, so she has a trach and we do have a passing mirror. When she has, when she has just her HME on, she doesn't like really drool from her mouth. So I'm assuming she's swallowing her saliva. But when she has her passing mirror on, she's like, I'm sure you guys are aware how the passing mirror works. It pushes everything up and she's supposed to be able to swallow. At that point, does that mean because she's pushing like the saliva out her nose and her mouth, does that mean she's not swallowing at that point? She needs to like kind of get adjusted to it?
I would say so. I think if it's coming out of her nose as well, I think that has to do with like the back of the throat, or not the back of the throat, but
her palate.
Yeah, the palate, where right where it splits to go either air to the nose or air to the mouth, there's a little flap there. And so if that's trying to close appropriately and coordinate, I think it's more of a coordination issue. She's probably trying to figure out how to coordinate her muscles in the back of the throat and at the back top of the throat to bring everything down. And some of it ends up going up the wrong way. So I think she's trying to figure out the pressure, and because there's a difference in pressure there when you put the valve on. And so she's trying to figure out how to coordinate that.
So, so for her benefit, it would be more for me to like put that passing mirror on more often so she can figure out how to work it correctly.
Correct.
Okay.
You can talk to your pulmonologist a little bit more about the passing mirror valve, but from my experience, typically instead of doing really long periods of time, they have you start with short periods of time and more often throughout the day. And then you can start to work up to having it on for longer periods of time each time until eventually she can have it on all the time. So, and that'll help a lot, because obviously if that hole is open, you know, the pressure to swallow isn't there. And so having the passing mirror valve on, which is what I was saying earlier, is really crucial and important. But you want to do it at your child's pace.
Yeah.
Too much. So, but that's a good start. Very, very good.
Okay, that's I wasn't quite sure about that. So thank you so much for that.
Of course. And try using also some of the stimulating exercises we talked about, like from the back of the tongue to the front, helping her just swallow, so that the more she swallows while it's on, the more she could get at the hang of coordinating, bringing it down rather than everything coming back up.
Yeah. Because that probably has a lot to do with her, her maybe possibly spitting up too. Is that, you know, she's that was a question I had too. Is like, is she like she's swallowing too much saliva, which is causing her belly to get full, and when she eats, because currently so she doesn't her feeds, she's on the pump, and she does like a 400 ml bag in like 3 hours. And so she's on a 3 hour feed time, and then she has 2 hours off, and then it's like another 3 hours. And you guys were mentioning like doing 30 minutes as a feeding, which makes a lot of sense, because that's how normally we all would eat, was like you eat for 30 minutes and then you have like a couple hours off, and then you eat like again. So,
I would talk to your doctor about the reasons why they're doing it that way. Because there might be something that we, haven't considered, or we don't know the background of as to why they've decided to do those 3 hour feeds with that much time.
Yeah, I think they're just trying to get a lot of food in her, and
Yeah.
and so they push it for a really long time. And yeah, it's so frustrating to have a special needs child and having to like try and figure untypical.
A lot of work.
It's a big puzzle, honestly. I think most families that we've worked with, we hear so many similar stories, and it's a very big puzzle and takes a lot of patience and working through it, a lot of trial and error. And so families, I think, are just trying to do the best they can and trying to figure out how everything works. And so often, you know, talking to other families about their experiences has helped a lot of my families. But yeah, something in regards to the throwing up, though, I was going to mention, talk to them also about the volume, because something I find sometimes, and again, I'm not, you know, a registered dietitian or anything, so I can't really speak too much for this, but I find sometimes kids will come in with this, you know, calorie count or volume that they're supposed to and have to take in. And I think sometimes families will feed their kids and the child might be getting uncomfortable already, showing that they're not wanting to, or they can't take in anymore. And we're still feeding however much we're supposed to give them. And so I think sometimes kids vary in how much they can tolerate. And so I've had families work with or kind of mess with the volumes a little bit. And they do that on their own to see if sometimes that helps. But again, talk to your GI, and I would talk to a registered dietitian to work out some of those things.
Yeah, I think Legend is also suffering from a gastric delay, because she, like, I'll feed her, and then 2 hours later, all of a sudden she'll spit up. And I'm like, okay, where did this come from? That should have been gone already. So we got a few different issues going on in our household.
Yeah. Yep. But working through it, it looks like you're trying to work through it little by little. So that's good.
Yeah. Well, honestly, thank you guys so much.
Thank you. Carrie, I just saw your message. So when you say that his tongue movement, so he was delayed in starting his tongue movement, meaning that what probably happened is the food went back into his throat before he was ready to swallow, and so he aspirated that food because and often that happens with that lack of sensation. Like you said, you'd like to find ways to make him more aware. Do you know what consistency it was on when that happened? Yogurt and liquid. Yogurt is kind of tricky because it's thicker, but then when you put it in your mouth and it heats up or it warms up, it turns into like a liquid. So that is a tricky one. What I would recommend doing, does he follow directions yet? Okay, so then what you can do is, seltzer water, like carbonated liquid, like LaCroix, or something that's flavored but has those bubbles. So that provides a lot of stimulation and input, and giving him that input can make him more aware, but he's still kind of working on liquid. So I would try maybe doing small spoonfuls, or like a small dropper of that carbonated liquid, putting it in his throat. Make sure that if his head is back like this, all of that liquid is just going to fall back. So we want to make sure that his head is his chin is down, even if that means that you're supporting his head as you're giving him the liquid. But that's a good way of making him, or giving him, like, more awareness to liquid and trying to get him to coordinate that movement before swallowing it, or swallowing it with more coordination. The other thing that I would work on with him is just increasing that tongue movement. So for him, when he feels the liquid in his mouth, or the yogurt in his mouth, he needs to swallow it right away. We want to increase the timeliness of his swallow. If you have like a tool, like the oral probe or a Z-Vibe, Another option that I really like are those like oral toothette swabs. They're kind of like a little spongy square, and it has a little stick. It looks like a lollipop. You could get them. They have them in the hospital or like at a dentist office. You can also order them on Amazon. Putting some yogurt on that or some liquid on that. I would do yogurt, something a little bit thicker. Pushing it onto the base of his tongue and swiping forward you're going to work on that swallow and the timeliness of that swallow. When we put yogurt, if we put yogurt like at the tip of his tongue or behind his teeth or something like that, he has to really work hard to pump his tongue and get the yogurt to get to the back. So we really want to just work on him like swallowing more quickly, and we can do that by giving him pressure on the base of his tongue. Okay, you're welcome. Does anyone have any other questions, or we can table this and have a more specific exercise session next time, or showing you guys the exercises next time?
That sounds wonderful. Thank you guys so much for doing this. This was
great.
This was great.
Thank you guys so much for being here, and we will talk to you soon.
Have a wonderful night.
Thank you. You guys too.
Okay, bye.
Good night. Thank you guys.